Vanessa, can we talk or not?
Doctor, we are live.
اوكي بس ما في صوت ما في شيء مش حاطين انتوا يعني we can start قصدك؟
Doctor, we have a timer. We will start in 3 minutes.
اوكي
Hello, Fadi, you want to start?
Yes, hello, I'm waiting to the approval of Vanessa. Can we start with Vanessa?
Yes, Doctor.
Okay, excellent. So, okay, good evening, everybody. مساء الخير جميعا. It's with great pleasure that I will be introducing the session today. Usually, it's the job of our colleague, Dr. Sami Al-Khatib. Dr. Sami today underwent a small surgery. نتمنى له الشفاء والسلامة. That's why I'm taking this role. Welcome again to the session of ABC educational course. As you know, the ABC Oncology educational course is an activity that is now regional and including different modules about all cancer. Now I will be introducing Mr. Chairman, Dr. Jean Sheikh. He's Associate Professor of Clinical Medicine at the American University of Beirut, Lebanon. He's a great man, he's a friend, and he will be sharing the session. I allow myself to thank all the invitees, to thank all the attendees, and to thank all the speakers and the panelists. The floor will be yours for the remaining time, Dr. Jean Sheikh. Thank you very much.
Thank you, Fadi. Hello, everybody. Good 'm really delighted to share this session with all the leader from the Arab country, coming from different country, from Syria, Lebanon, Jordan, Sultanate Oman, Qatar, Tunis. So really, I'm delighted to share this a highly interesting meeting. And I want to thank our sponsors and Dr. Fadi Farhat to give me this big opportunity to share this session. As Fadi said, Dr. Sami Khatib, our Secretary General of Arab Medical Association Against Cancer from Jordan, is not able to be with us today, and we hope he will get better and well as soon as possible. So we will start our first session presented by Dr. Nabil Shamsuddin about what are myeloproliferative neoplasm. Dr. Shamsuddin is professor of clinical medicine, hematology oncology at Medical School, University of Balamand, and also associate professor of medical oncology at Medical School, St. Joseph University, Lebanon. The presentation, I think, of Dr. Shamsuddin, it's a recorded session. If we can start. For the audience, we are reaching now on the screen almost 101 attendees. So excellent for everybody to be a lot in this webinar. And we hope to. If we have any question, please raise your hand at the end of the session. And also on the chat, you can write your question. And based on our time, we will try to manage our question.
Nous allons répondre à toutes vos questions.
Okay, please, we can mute all the microphone, and we will start with the first presentation by Dr. Nabil Shamsuddin.
Good evening. I am Dr. Nabil Shamsuddin, and I am very happy to join this meeting under the supervision or organization of Dr. Fadi Farhat and Sami Khatib. I will talk about myeloproliferative neoplasm, and as you know, it is a not very well-known neoplasm, and the classification has been changed and modified last years. But the main challenge is the classification. Like all disease, the classification is very important to make a good diagnosis, and a right diagnosis with the corresponding prognosis. These are the main factor to have an effective treatment. So these are my disclosures. I declare no conflict of interest about this presentation. And the concept of myeloproliferative disorder is very old. We have to go back to William Dameshek, who was the first to identify the three diseases which we know: the polycythemia vera, the PV, and the essential thrombocytosis (ET), and primary myelofibrosis (PMF, as three related entities about within one single group of myeloproliferative disorders. Nowadays, we do not say any more disorders, but we say neoplasm. Subsequent study demonstrated that PV, ET, and PMF are clonal disorders, so it is the first step to be malignant ones. And the malignant cells is, like always, is a progenitor. It's a multipotent, so why we have the three lines of the hematopoiesis which are expressed in proliferating. Also, several study has noted this related expression of specific genes like MPL, the receptor of thrombopoietin, or the BCL-XL, which is now very well studied in CLL, and the PRV, the polycythemia-related polycythemia rubra vera, the one which is a genetic basis for these disorders. It's staying to be elusive for many years, until 2005, until 2005, when Dameshek, Falco, and Adamson and Pershal converged with the identification of the JAK2 was the mutation V617F, valine to phenylalanine allele, in the majority of patients with PV, ET, and the PMF. And this gene, we have at least the three JAK1 and JAK2 and JAK3, and another gene related to the Janus family. And the mutation is most often, and more than 90% of the mutation is within 95% of the mutation of the mutated genes are within the pseudokinase domain, which is normally is an inhibitor kinase for the true kinase domain. Donc the V617F is the most common mutation by far, but we do not forget that we have also a mutation of exon 12 mutation. This domain of GH2 and GH1 is cytoplasmic domain. We have also on the right, you have the what are proposed already by Damishek as a pathophysiology of the three proliferative disorders, PV, MF, and ET. But we have added now our common beliefs that we have a hematopoietic stem cells, which has been modified by other mutation than the JAK2. We don't think that the JAK2 is the first initial mutation of the leukomogenesis, and you go for on the left or on the right or straight. So from PV, ET, and MF, and primary myelofibrosis. Other than the JAK2 mutation, we have the MPL mutation, but the MPL mutation give you only ET or MF. The JAK2 is more general in the activation. It can activate the erythropoiesis and also the myelofibrosis, leading to also to ET, or go directly to the myelofibrosis. And the MF can be the end of the post-PV or post-ET evolution to myelofibrosis. You understand, just starting now, that something else must be dictating why the mutation in JAK2 V617 go to PV or to ET. It's not only a matter of load, of burden, of homozygosity. Still, the homozygosity will go up for the PV, but something else must be either the environment of the myeloma or other mutation which lead to pure ET and for all the life of the patient of the ET. The evolution to MF, either from PV or ET, is also secondary to other mutation or other epigenesis modification leading to PMF. But do not forget that we can go directly for a pre-PMF and PMF from the initial mutation. Here is a schema. It is known that we go directly on the D and E, and we know that mutation in JAK1 or JAK2, specifically JAK2, which is often observed in myelofibrosis, PV, and ET, can lead to constitutively active JAK function. And the JAK1 now is very a la mode because it can be investigated in very in inflammatory disorders and autoimmune disorders. And because we know that because the anti-JAK2, which is not an anti-JAK2, it's an anti-JAK2 and JAK1, the ruxolitinib, we know that it is very good drug, anti-inflammatory good drug. So the JAK1, maybe it is the activation of JAK1 or the molecule, the protein synthesized by JAK1, the activation lead secondary to JAK1 activate is leading to inflammatory process. The JAK3 also has been observed in patients with acute megakardioblastic leukemia in around 20% of patients. So on the left, it's a very good resume that the definition of PV, without going to the further slides, the WHO 2016 classification, easily way, to see that if we have PV, if your hemoglobin is sustained more than 18.5 grams for male and 16.5 for female, and more than 95%, 96% of patients have JAK2 V617F mutation, we will say further JAK2 mutated. And you have the myelofibrosis, 50% have the JAK2 mutation and 50% also for ET. For the other 50% in MF, we go for the ML, the mutation of the MPL of the thrombocytopoiesis. The passage from PV to MF or from ET to MF is around 10% per 10 years for each PV or ET. But the transformation to acute leukemia, either the patient has taken hydroxyurea or not in the old series of PV, I think that it is not a leukemogenic hydroxyurea for PV, and it is a spontaneous evolution with time to acute myelogenous leukemia. 5 to 15% of PV patient transformed per 30 years to AML, and less than 1% of ET. The less propensity to leukemogenesis is for ET patient. The MF is close to the PV. It can go for acute myelogenous leukemia also. And on the right, you see that for a patient, we can have JAK2 negative AMLs, even if he is previously JAK2 positive MPD. So most probably, this mutation can be emergent from a pre-JAK2 mutation cell progenitor pre the mutated stage, and with time can go for leukemogenesis. But most of the transformation of the PV or of the MF are from the same clone of JAK2 mutation. Still, exception confirm l'exception confirme la règle. Now we will go to the hard series of slides of the true definition of myeloproliferative neoplasm. The myeloid neoplasm in the 2016 WHO classification has been classified in acute and in chronic. I will deal only for the first of the all. We will deal for the myeloproliferative neoplasm. Secondly, for the myeloid or lymphoid neoplasm associated with eosinophilia, and finally for the MDS, MPN borderline syndromes, and we go further. So for the PV, it's very easy. There will a debate about taking hemoglobin or hematocrit as criteria. I believe that hemoglobin is very easy, and for me and for many physicians, still the hematocrit. I go for hematocrit, but the WHO has chosen the hemoglobin because it is less. We have less false results by the machines. But the hematocrit, the value of hematocrit is more close to the clinical consequences of high RBC volume, mass total, yani total volume of RBCs. So the definition is hemoglobin, high hemoglobin. The bone marrow biopsy has been trilineage growth. So trilineage growth, we have a pamylosis, including erythroid, granulocytic, and megakaryocytic proliferation. We don't have overwhelmed erythroid hyperplasia. The three lines is equally, if you want to say, are equally hyperproliferated. And you have the presence of JAK2 mutation. But when we go to the peripheral blood, we go for hemoglobin, we go for the bone marrow biopsy, which is dictated obligatory by WHO, and the presence of JAK2. These are the major criteria. The minor criteria is EPO level very low. If we go for the note in red, I think the bone marrow biopsy is the most controversial required criteria. I personally do not go for bone marrow biopsy unless I want to evaluate exactly if there is a concomitant myelofibrosis secondary to, not the primary myelofibrosis, but reactive myelofibrosis from the start of the diagnosis, because it is a predictor of more rapid progression. But for strict definition, if I have more than 18.5 grams of hemoglobin and I have splenomegaly and I don't have any other and I have the mutation of JAK2, I think there is a very little, small room of hesitation about the diagnosis. Still, the recommendation is to do a bone marrow biopsy. For the morphological molecular and clinical picture of PV, erythrocytosis, leukocytosis, and thrombocytosis. So why we have the term of polycythemia? So we can say polycytosis, polycythemia, the three lines, the blood, and EPO very depressed, and you have the bone marrow for the age, but without predominance of any line. The molecular driver genes you have in 96% JAK2, the classical one V617, and the exon 12 in 4%, less than 1%, less than 0.5%, and we think that it doesn't exist that we have polycythemia vera, true one with JAK2 wild. The clinical outcome, the PV patients are at increased risk of thrombosis and may progress to myelofibrosis. We saw that in previous slides. Let's go to the ET. The platelet count is very high, more than 450,000 per millimeter cube. Bone marrow biopsy will show here. We have to go for, we will show increased number of enlarged mature megakaryocyte with a normal disposition bone marrow biopsy. Not meeting, always not meeting the BCR-ABL positivity, not meeting the criteria of PV and PMF, no myelodysplastic signs, and or other any disease. Presence of JAK2 calreticulin or MPL mutation, you know that 50% is a JAK2 mutation, and 40% of the 40 and 60%, I'm sorry, 60% of the other non-JAK2 mutated are calreticulin, and maybe 20-25 MPL mutation, and 10% are no known mutation between these other mutations than the three genes cited here. The main criteria, you have a clonal marker. When we don't have JAK2 mutation or CALR mutation or MPL mutation, you go for another mutation by NGS request. So the diagnostic requires ET, all 4 major criteria, or the first 3 major, and the and it's very well known by our by you and by all the specialists of hematology, and most often this dilemma doesn't exist in a real practice in our clinics. So the morphological, molecular, and clinical picture, you have thrombocytosis, normocellular bone marrow. Look, we don't have palm myellosis like in PV. We have normal cellular bone marrow, but we have proliferation of megakaryocytes. The JAK2 is mutated in 60 to 65%. CALR is between 20 and 25% of all patients. MPL exon 10, yeah, what we call the canonical MPL mutation, is in 4 to 5%, and less than 1% in non-canonical MPL mutation. You have this mutation in the bottom of the slides. The clinical outcome is the most benign, if you want to say, between the myeloproliferative neoplasm. It involves increased risk of thrombosis and bleeding because some platelets are thrombopathic and may progress to more ugly rare. It's less than 2-3% of transformation to acute plastic transformation, but it can evolve to more severe neoplasm like MPF. We have what we call the post-ET PMF, MF myelofibrosis, like we have also the post-PV myelofibrosis. The calreticulin mutant are the lowest risk of progression to myelofibrosis and to thrombosis. That's important. And triple negative ET is an indolent disease. In contrast with the triple negative PMF, we will see next this characteristic. For the PMF, we have the overt primary PMF, and we have the pre-fibrotic MF. So the overt myelofibrosis, you have here proliferation of megakaryocyte, you have either reticulin or collagen, but we must have a grade, as major criteria, we have the grade 2 or 3 myelofibrosis, not meeting the WHO criteria of BCR, ABL, PV, ET, myelodysplastic syndrome, or other myeloid, and presence of JAK2, calreticulin, or MPL mutation. Or in the absence of this mutation, you go for another clonal markers, or absence of minior reactive bone marrow reticulin, secondary to infection, autoimmune disorders, or other chronic inflammatory condition. Hairy cell leukemia, it's very typical for pathologists to distinguish between the fibrosis of hairy cell leukemia and fibrosis of primary myelofibrosis or other lymphoid neoplasm and other. It is a problem not easy, but very well known by the pathologist. The minor criteria is anemia not attributed to a comorbid condition, leukocytosis, palpable splenomegaly, LDH increase, or leukoerythroblastosis. Whenever you have erythromegaly or leukoerythroblastosis, diagnosis become more easy to go and to sum all the criteria. The diagnostic requires diagnosis of over PMF requires meeting all the three major criteria and at least one minor criteria. I'm sorry, we go always for the WHO classification, but you have the clinical sense to do a good diagnosis. I go rapidly for the prefibrotic primary fibrosis. Here, the pathologist it is the pathologist who will say us, it is a prefibrotic primary myelofibrosis or ET, because the differential diagnosis is between ET and between the ET. And you go here, it is this plastic megakaryocyte and the absence of grade 2 and 3. We have to we don't have more than grade 1 fibrosis, and we have a typical megakaryocyte. I go rapidly because of the time, because I'm running. I'm sorry, but je vais très rapidement pour respecter les 25 minutes de conférence. So, by morphology and molecular clinical data, in prefibrotic PMF, you have various abnormality of peripheral blood anisopoikilocytosis and teardrops. You have granulocytic and megakaryocytic proliferation in the bone marrow, which lack of reticulin fibrosis. And in the over PMF, you have various abnormality of peripheral blood, and the atypia in the bone marrow of the megakaryocyte is more pronounced, and you have a clustering, and you have abnormality of disposition of megakaryocyte related to the bone the trave osseous. The driver gene is already like the NET. You have 67% JAK2 mutation, MPL10 4 to 5%, and another reticulin in 25 to 30% of patients. And we go down, the triple negative PMF is the most aggressive form of PMF. So here it's already said that it's the role of the pathologist to say if it is early prefibrotic myofibrosis of essential thrombocythemia, it is the disposition of megakaryocyte between others, and the clustering and the atypia of nucleus, and it's a role of pathologist, and the pathologist must say we have fibrosis grade 1, but we have abnormality, we don't have abnormality of megakaryocyte, so we go for essential thrombocythemia. So hypercellularity, بالessential thrombocythemia, it's age-matched cellularity. If you have prefibrotic extensive and dense clustering and translocation towards the endothelial borders, we don't have erythroid or neutrophilic myeloproliferation in ET. So the MPN driver, that's I will go directly. These are the other clonal mutations which are very associated with myeloproliferative neoplasm. Don't forget, it is most of them are epigenetic genes. Genes intervenant dans l'épigénie, as epigenetic is a modificateur of DNA. You have the DNA methyltransferase. You have the TET1011 translocation 2. You have the AXL mutation, the enhanced zest homolog 2, and as TP53, of course, which is very bad marker of malignancy and we have also prognostic models for polycythemia vera. We have prognostic models for primary myelofibrosis. Here we have integrated prognostic model for myelofibrosis, which is the most adverse, la plus sérieuse des myeloproliferative disorders. So we have integrated. Rumi has Elisa Rumi take the classical IPS. You know of it. We go for the book to see the 5 criteria, which are the same 5 criteria for all myeloproliferative neoplasm: age, hemoglobin, white blood cells, blast percentage, and constitutional symptom. But here he added if we have JAK2 or JAK2 MPL color triple negative, and when he integrated on the right, we separate more easily very low risk from low risk, from intermediate, and the high risk and very high risk are very close each to other. If we go only for the mutation, you see that the triple negative is the most adverse set of patients. So, 2 words about the chronic neutrophilic leukemia. Chronic neutrophilic leukemia, you go for the presence of colony-stimulating factor 3 receptors. It's present in 80% of cases, and when you have it, you have a good you are sure that you have a chronic neutropenia, because it is very difficult to say chronic neutropenia or the atypical CML, because we don't have BCR-ABL1 here. So not meeting WHO criteria of BCR-ABL1 positivity, CML, PV, ET, or PMF, but we have in myelemi peripheric, and we don't know you have a peripheral bone marrow. If you have the CSFR, it's a go for a chronic neutrophilic leukemia, which is not a very easy disease. But do not forget that sometimes we have neutrophilia secondary to plasma cell neoplasm. And if you have a plasma cell neoplasm, demonstration of clonality of myeloid cells by cytogenetics or molecular study will go you back to the right diagnosis of chronic neutrophilic leukemia. Now we go for the myeloid lymphoid neoplasm, only states that we can have eosinophilia in the Myoperative Neoplasm associated with this mutation, PDHFR alpha, you know, the sensitivity to imatinib, or beta, or PDHFR beta, or FGFR1, which is not very easy to be treated by tyrosine kinase inhibitor, or the very highly associated one of Myoperative Neoplasm with PCM1 pericentricular mutation, JAK2 rearrangement. It's very easy. It's very may respond to JAK2 inhibitor and can be associated with lymphoblastic lymphoma or acute lymphoblastic leukemia. So the myeloid lymphoid neoplasm, we can have lymphoid neoplasm, of course, clonality on the lymphoid, but here I am only talking about myeloid neoplasm. You have the quoted one is the PCM-JAK2 mutated, and it is responsive to JAK2 inhibitor ruxolitinib. And to finish my talk, you have the CMML as border overlap syndrome, myelodysplastic syndrome, myeloproliferative neoplasm. You have the chronic myelocytic, and you have the MDS-MPN with ring sideroblast and thrombocytosis. MDS-MPN, ring sideroblast with thrombocytosis. So it is classical to say that MDS we have ineffective myelopoiesis. In MPN we have super effective hematopoiesis with no loss of maturation. So dysplasia is absent. It is another way to see that we have MDS on the left and we have the MPN on the right, and in the middle we have the overlap syndrome. You have the CMML. Do not forget, we must have more than 1,000 monocyte per millimeter cube without diagnosis, and we accounting, and at the same time more than 10% of the white blood cells. You go for the all not meeting WHO criteria of CML, PMF, PV, ET, no evidence of mutation going for the eosinophilia, dysplasia in one or more myeloid lineage. If myelodysplasia is absent or minimal, the diagnosis of CML may still be made if the other requirements are met, yani the 3 above, acquired clonal cytogenetics or molecular genetics. The monocytosis has been, if we don't have nothing, and we don't have cytogenetic or molecular genetic abnormality, we have the 4 first criteria. The monocytosis must persist at least for 3 months, with all other causes has been eliminated. It is a prognostic motor for Idh. Remember, we have the dysplastic type when the white blood cells is less than 13,000, and we have the proliferative type when the white blood cells is more than 1,300. And you have a recent article in CMML with some excess of blast, with some proliferation, where venetoclax with azacitidine has been effective published in the late ASH 2020. For the MDS MPN ring sideroblastic thrombocytosis, you go for the sine qua non mutation, defining mutation, the splicing factor 3B1 mutation, and you have to eliminate always no CML, ABL, BCR ABL1, PGFR alpha beta or FGFR1 or PCM1 JAK2, and no translocation 3, inversion 3 or deletion 5q. If I know to mention for the next 1 minute that NGS become a must of diagnosis or the equivalent of NGS by different PCR for different mutation to do a good diagnosis. So a good diagnosis, good prognosis, good choice of treatment. Thank you. And thank you. It's all. Thank you for your patience. Bye.
Thank you, Nabil. I don't know if Nabil is now with us. Anyway, it was a very nice presentation, a general overview about the new diagnosis of MPN. A highly educative presentation from Nabil. As Fadi mentioned before, Dr. Khalid Ibrahim is not able to be with us this afternoon to present the primary myelofibrosis about the update in 2021 on diagnosis, risk stratification, and especially about the management of the disease and the new treatment. So I will prefer to go directly to present our colleague from the panel. We have Dr. Zahira Fahad. Dr. Zahira, consultant in hematology oncology at Dar al-Shifa Hospital in Syria. Welcome, Dr. Zahira. We have Dr. Ala Adasi, senior consultant in hematology oncology at Al Khalidi Medical Plaza and founder of and director also of Lymphoma Service Program at King Hussein Cancer Foundation Cancer Center in Jordan and Amman. And Dr. Reem Al-Fatimi, Associate Professor of Hematology and Secretary General of the Tunisian Society of Hematology from Tunis. Welcome, dear colleague. I don't know if we have some question from the audience. No, we have from the organizers. They are telling me that Dr. Nabil Shamsuddin is not with us. So for the panel, I think we can share our experience. Actually, we are from different regions, from Syria, from Jordan, from Tunis, and us from Lebanon. So we can share maybe our experience in the treatment and the management in 2021 of myeloproliferative neoplasm. Did you have, Dr. Zahira, can you have some comment about the management of the myeloproliferative neoplasm actually in Syria during the last year? Are you able to do cytogenetic molecular studies? Are you referring this molecular test and this test to other centers or maybe in Europe? Because you have some connection with Saint Louis, I think, no? Can you have some comment, Dr. Zahira, please? You should unmute yourself, Dr. Zahira.
It's okay now?
Yes.
Do you hear me?
Yes, go ahead. Thank you.
Yes. Okay, thank you, Dr. John. Okay, thank you very much. In Syria, actually, we have the possibility to make our in our lab karyotype and some mutations. Well, now we are having NGS also, but in private sectors. So our patient can do what we want from him. But what I want to ask to our if there's any need to make RAS CBL mutation before starting treatment by ruxolitinib? This is a question from our colleagues in Damas. So can somebody answer this question? Hello, are you hearing me,
Yes, we have
Dr. Jean?
yes, Doctor. We have some interruption, but I think the audience and the panelists had got the question. Basically, we are not based actually on the treatment to do the RAS, or maybe in multiple center also in Lebanon, they are doing only the basic test, bone marrow biopsy, cytogenetic if possible. But we have at our center in the American University of Beirut, a lot of patients refers from different institution, peripheral hospitals from outside, from Iraq, Syria, etc. And we are managing this patient without any initial, at baseline, any cytogenetic or molecular testing. So the treatment with ruxolitinib is not related to the presence of JAK2.
So if patient with resistant to RAS, you are
Sorry, can you repeat? Anyway, as I said, and it was clear in the presentation of Dr. Nabil Shamsuddin before, we have a lot of patients with myelofibrosis, either primary or secondary, without JAK2. So for those patients, we can start anyway the treatment with ruxolitinib, independently from the positivity of the testing. So the treatment with ruxolitinib should be started if we have the diagnosis of myelofibrosis, and not only in the case of positivity of the test. I don't know if Dr. Zahira is still with us. Anyway, Dr. Ala from Jordan, the same
Excuse me.
question. Sorry.
I have some problem in
It's okay, Dr. Zahira. There is a lot of interruption in your connection. So maybe if you want, you can write your question or your comment. It's better, and we can read it. Dr. Jean, you missed our colleague from Oman. So we are also from Oman, not only Lebanon, Syria, Tunis, and Jordan.
No, I cited our colleague from Sultanate Oman. I'm sorry if
I missed it. It's okay.
So, Dr. Ala from Jordan, King Hussein, obviously one of the biggest center in Jordan. The same question actually about the cytogenetic testing. Are you performing, an example, allogenic transplant for those patients, especially for the young patient in the new era of ruxolitinib? Or you are referring this patient to another center outside Jordan? What is your actual management of myeloproliferative neoplasm, especially myelofibrosis, in 2021? Anyway, the same question from me to Dr. Reem Al Fatimi, if she can. Dr. Reem is with us. I can see her. Hello, Reem.
Hello, thank you for your invitation, and thanks to Dr. Nabil for the excellent presentation. So in Tunisia, we actually perform cytogenetic testing in many laboratories, and we search for until a week ago, we have been searching only for JAK2 mutations, but luckily since last week we implemented the calreticulin and MPL mutation search technique. And so we do that for all patients with myelofibrosis, primitive myelofibrosis. For patients, for young patients eligible to transplantation, we refer them to our National Center of Transplantation if they are young and they are eligible and they are eligible to transplant. This is our attitude in Tunisia.
Okay, thank you so much. We have a question from Anonymous. I don't like Anonymous anyway. Also from some patient, Anonymous, who sent some question on WhatsApp. Anyway, in summary, final diagnosis of polycythemia vera is by using. So I don't know what. Anyway, it was clear in the presentation. If you followed the presentation of Dr. Shamsuddin, he put all the criteria of the diagnosis of polycythemia vera in 2021 based on the new WHO classification, basically the hemoglobin and the hematocrit. And as you know, the treatment is also clear depending from the severity of this disease. Obviously, the treatment with ruxolitinib is basically still one of the best choice, actually, if the treatment is available. We have time anyway for this panel discussion because we missed the presentation of Dr. Khalid. I will try to be fast, and we can also discuss maybe if the audience is interested about the indication of a transplant and the new era of ruxolitinib in the treatment of myelofibrosis. It's a big debate, not in our country, and our region, but also in Europe, US. We have ruxolitinib, we have the new drugs coming soon for the refractory patient. However, for the young patient, fit patient, after some months of treatment with ruxolitinib, reducing the splenomegaly, improving the fibrosis in the bone marrow. If we have a compatible donor, so the first choice is to go to allogenic transplant from this compatible donor. In our region, we have, as you know, the accessibility only to matched related donors. We don't have access to unrelated donor for different reasons. And recently, we have in some centers the accessibility to do transplant from haploidentical transplant. And the cord blood in US and Europe is not a good option for this, specifically for this typical disease. So if you have a young patient with splenomegaly and with myelofibrosis, primary myelofibrosis, treated with ruxolitinib, he had some reduction in the splenomegaly, improvement in his count, no transfusion dependence, or at least a little bit transfusion dependence, and you have a compatible donor. Did you go to transplant? Did you refer the patient, or did you continue the ruxolitinib? Can we have a round table, please?
So, in this case, we have to, Dr. Jean, can I proceed?
Yes, go ahead.
In this
Zahra.
case, we have to make our stratification of the patient by prognostic scoring system, either MIPSS or GIPSS. So if the patient is
let's say you
by
have
high
a
risk
patient. Dr. Azela, let's say,
Yes.
I'm sorry, I should be more specified. Let's say we have intermediate, high or high risk patient, young, fit, treated for 9 months with ruxolitinib, no splenomegaly, and a reduction to his transfusion dependence, and he had a compatible donor. What is your therapeutic plan for him?
For this young patient, I will send him to transplant.
Where?
In Syria, we have allogenic transplantation if he has a donor, so he must go.
Excellent, excellent.
What do
Dr.
you
Arim?
think?
I fully agree.
It's a really debating subject, but I think I will send him for transplant too, because it's the only potential curative treatment therapy for myelofibrosis. If this patient has the chance to be young and to have no comorbidity and to be eligible for transplant, and to have a donor also, I will send him for transplant too.
And you are performing allo transplant in your center?
Yes, since 1998, we perform allogenic stem cell transplantations from matched-related donor only, no unrelated allogenic stem cell transplantation, and no identical for adults. We do identical transplantation for children only, actually.
Okay, great. So my second question, let's say we don't have a compatible donor for him. Did you continue ruxolitinib, or we will try to go to transplant from haploidentical transplant donor?
Anyway, this is very risky for this patient because the outcome of transplantation in this patient is not very good. Either it's about 55% curative. So if this patient has no other choice, we maybe proceed to haploidentical transplantation.
Okay. So
know what you are
the question
about.
The question, we don't know really the good answer. It's really a debate. Obviously, it was clear for the high-risk patient to proceed directly to transplant if we have a full match donor. The second option, there is two independent and different strategies. The first one, to continue ruxolitinib till progression, and anyway, it will be risky to go to transplant from haploidentical transplant when we have a disease with splenomegaly, with transfusion dependence, and more fibrosis in the marrow. So the risk is higher, obviously. The other hand, if we go directly when the patient is responding to ruxolitinib, and we prefer to proceed to transplant from haploidentical transplant, obviously the risk is lower, is not zero, but maybe we are offering the, as Dr. Arim said, maybe the chance to be cured from this incurable disease. So it's debatable. We don't know a lot about the type of conditioning. When we need to stop ruxolitinib before a transplant, should we continue ruxolitinib till the transplantation and maybe later on, or maybe to stop ruxolitinib 3 weeks or 3 months before the treatment, taking the risk to progression before the treatment, before the transplant. So there is a lot of very open question. However, recently we got a publication from the French group and from the EBMT in parallel from the group of the Chronic Leukemia Working Party and Professor Kroger, showing that transplant for myelofibrosis and from haploidentical transplant is totally a feasible option with, as Dr. Fahad said, we had almost 30% transplant-related mortality after haplo, which is 1/3 of the patient die from the transplant complication. On the other hand, we have a progression-free survival optimal, but we should take this high mortality rate into consideration. Maybe we need different approach, different supportive care, maybe different management of ruxolitinib treatment before transplantation. I don't know if I saw Dr. Aboud.
I want to ask about conditioning.
Yes. Basically, for the conditioning.
Dr. John, what about conditioning? These patients are very sensitive for sensitive to chemotherapy, so we can go to reduce intensity conditioning.
Yes, if you have a young patient, basically
myeloablative.
For the young patient,
condition.
Yes, for the young patient, if the patient is fit with no comorbidity, basically we need a more myeloablative conditioning. Because as you know, we have the splenomegaly before, we have the fibrosis, maybe it's better with ruxolitinib, but it's not an optimal microenvironment for the transplantation due to the fibrosis. So for the young fit patient, the myeloablative conditioning still and remain the first option for those patients with a considerable transplant-related mortality later on. However, for the elderly patient above 60 years old with, or maybe younger, but with some kind of comorbidities, the reduced intensity conditioning is the option with less transplant-related mortality, around 15 to 17%. However, the progression rate or the risk of non-engraftment, or maybe the risk to do some kind of boost of the CD34 post-transplant still an option or may be needed. But as we said before, you should balance and manage between the risk and benefit, taking into consideration the risk of the patient, the age, the comorbidities, and obviously to get a good engraftment without a high risk of mortality related to transplant.
What about pre-transplant splenectomy?
In general, in the last year, maybe my colleague can comment also, with the ruxolitinib, maybe almost 80% of the patient had a spleen reduction if we have the possibility to give the treatment on time with the correct doses regularly. So the splenomegaly with the ruxolitinib era is not anymore a big issue. For the patient who are refractory, the splenectomy could be an option. However, you should take into consideration those patients are severely thrombopenic. There is no surgeon available maybe to take the risk to do splenectomy for those patients with severe neutropenia, severe thrombopenia, the risk of bleeding. Radiation therapy, we used the radiotherapy on the spleen for many years to read the extramedullary hematopoiesis. However, and we did the transplant with a huge splenomegaly. However, all this option is still risky. For us, and for the chronic malignancies working group in the ABMT, we suggest to do, if possible, splenectomy for the refractory patient before transplantation and to proceed directly to transplant anyway.
Can I
What
comment?
about the radiation?
Dr. Jean, please.
Yes.
We are listening only for the Lebanese experience. We need the regional, please.
I
Please,
want to comment on it.
Dr. Reem, yes.
Yes, I want to comment on splenectomy before transplantation. I think it's important to have a reduction in spleen volume before transplantation, since it ensures a more chance for engraftment in post-allogenic stem cell transplantation. Actually, the ruxolitinib is giving us good results in spleen volume reduction. So we need splenectomy in a very this is what we do in Tunisia. Generally, we put patients eligible to transplantation on ruxolitinib. We maintain it until 2 weeks before transplant. And if the patient is ruxolitinib resistant and has a persistent huge splenomegaly, we do splenectomy before, if of course it's possible, before transplantation, because we had the experience of non-engraftment post-allogenic stem cell transplantation in patients transplanted with a huge splenomegaly, and we choose since that to reduce imperatively the spleen volume before transplantation.
I fully agree with this. I repeat, when it's feasible.
When it's
not
feasible,
always,
of course,
yes,
of course.
it's not always feasible, and we don't have always the kamikaze surgeon who want to go to splenectomy.
It's the surgeon do that with the cilioscopy, and actually it's surgeon that is c'est dominé donc de plus en plus, donc c'est.
Yes, there is some experience from the Chinese group or many other group. They are doing a combination with chemotherapy, some kind of chemotherapy with ruxolitinib to be able maybe to not to decrease at a maximum the spleen size, but also to help later on the engraftment, doing some kind of sequential treatment before transplant. Anyway, it was a pleasure to discuss with you this topic, and we are exactly on time, perfect time. For the first time, we are on time. Maybe I can introduce the second session. The second session, I will introduce my friend, my colleague, and Dr. Miguel Aboud. Dr. Miguel Aboud, professor and chairman of Department of Pediatric and Adolescent Medicine at the American University of Beirut Medical Center. Dr. Miguel will talk today about sickle cell disease, challenges and progress. Miguel, the floor is yours. Thank you.
Thank you, Jean. Thank you very much. A very interesting discussion on myelofibrosis, which fortunately we don't see in children. Now, I've just had a referral of a young boy who has by molecular diagnosis and by clinical features, great platelet syndrome, and he is having early myelofibrosis. So I'm discussing with experts on the syndrome whether to go to ruxolitinib or to transplant. And if I can, there's somebody else sharing the screen, so it tells me that I cannot share my screen. Okay, now I can share my screen. Okay, so I'm going to go, and I'm going to be giving an overview of the current management in sickle cell disease. And I have an apology to make. I prepared the slides, but I copied 3 or 4 slides that Novartis had sent me. So all of them have the Novartis logo at the bottom. But what I want to start by saying is that the management of sickle cell disease is a multifaceted approach that starts with comprehensive care in early childhood and for adults. So we need to have everybody involved, the pediatrician, the internist, the nephrologist, the neurologist, and so on. And we do go to more complex therapies like stem cell transplant, blood transfusions, or hydroxyurea. And hydroxyurea is a drug that is easily available, affordable, and can be really used for multiple causes. It increases fetal hemoglobin F and decreases risks of strokes and other end organ damage and prolongs life. Sorry, there is something wrong here. I apologize. Oops. This jumped about 200, okay. So I was talking about hydroxyurea. So the management currently involves hydroxyurea, blood transfusions, opioid analgesics for pain crisis, and bone marrow transplantation. Now, this is a slide from our colleague and fellow Lebanese and AUB graduate, Professor Samir Ballas, who really defined the painful vaso-occlusive crisis with a prodromal phase, an initial phase, and an established phase in the resolving phase. And what we need to know is that this crisis, as you see here, is going to last in one way or another 7 to 10 days. So there is a big move now to develop medications that do 2 things, that prevent it or that shorten it. Unfortunately, we have not been able to find medications that shorten the pain crisis. We have found medications that treat it, transfusions, opioids, IV fluids, occasionally analgesics, and prevention can be glutamine, hydroxyurea, blood transfusions, and that there is a clear unmet need for both prevention and for treatment to shorten this pain crisis. And these crises are the hallmark of sickle cell disease. In fact, in certain African languages, the disease is described as a pain, wachiwawa, a lot of pain and a lot of like eating away the bones. And of course, the pathophysiology is sickling, adherence of the cells, vaso-occlusion, and inflammation. And you can see here that the single point mutation in sickle cell disease in DNA, leading to hemoglobin S polymerization, leading to cellular adhesion, inflammation, activation of coagulation, and organ dysfunction. And all of these are targets for therapy. And this was published by my friend Krishnamurti about our job as physicians. And we can either be collaborative or proponents. And the proponents are people who inform the patients, but do not determine timing and type of treatment. And collaborative are people who are going to discuss with the patients and make joint assessments. And of course, the disease severity, the intensity, and the urgency of treatment play a role of where we are on this spectrum. Now, the first medication is hydroxyurea, a simple molecule that impacts sickling of red cells, influences adhesion of these red cells, decreases white cell count, and increases fetal hemoglobin in the red cells as well. Now, it is currently the only fully approved drug for the treatment of sickle cell disease. I'm going to be talking about two other drugs very soon that have partial or conditional approval, Adakveo from Novartis and Oxbryta from GBT. But sickle cell is really fully approved, and it decreases pain and acute chest syndrome, lengthens life, and induces hemoglobin F, decreases white count. It's a nitric oxide donor and decreases mortality. Now, there might be effects on fertility. This needs to be further studied, but we need to do more of this drug in our sickle cell patient. Still, for one reason or another, about 1/3 of half of the patients do not get on this drug, and some of them will not respond to it. So we need new drugs. What about the anti-sickling agents? First, I'm going to start with GBT440, which I told you has now conditional approval, Oxbryta. This is a molecule from Global Blood Therapeutics. It binds to the alpha chain and increases the oxygen affinity to the alpha chain. This will decrease the sickling and will decrease hemolysis. And in fact, this was the goal of these studies. The studies were aimed to look if we could have an increase of 1 gram of hemoglobin in patients. And you can see here that more than 60% of patients increase their hemoglobin by 1 gram. Now, of course, some patients did not, but that the higher dose, 1500 milligram, was more effective than the lower dose and definitely more effective than placebo. For this and there were only a small number of patients on this drug where the hemoglobin dropped, and this has been sustained over 24 weeks and now 57 weeks. You know, I'm going to be presenting the results of 57 weeks, but 47 weeks are superimposable. And you can see here that there was a decrease in the number of pain crises. Unfortunately, this did not reach statistical significance, but these curves remain to widen. And hopefully in the next analysis, we are going to see a decrease, a significant decrease in pain crisis among these patients. And you can see here that patients on voxelotor, the increase in hemoglobin was sustained over a long period of time. And this is the high dose, the low dose, and the placebo. You can see no increase in hemoglobin, but this was sustained. And this has been held out up to 54 or more weeks now. Now, the big disappointment have been the platelet inhibitors. We have tried prasugrel, and now we have also tried ticagrelor, and I have to tell you, we have just sent this paper for publication. Neither of these antiplatelet agents had any impact on decreasing the incidence of pain crisis in patients with sickle cell disease. And in fact, they were associated with significant side effects, so no use for the antiplatelet agents. The other drug that has been approved is glutamine, and glutamine is a non-essential amino acid. It's a precursor for the synthesis of other amino acids, and it improves the redox potential in patients with sickle cell disease. And here is the role of glutamine in providing glutathione and improving the redox potential inside the red cell. And there was a trial of glutamine versus placebo, which was the basis for this approval for the FDA. Now, this is approved in the US, but not in Europe. And you can see here the patients that were treated, use of hydroxyurea was allowed. And you can see here that time to first crisis was significantly increased in the glutamine arm. And also you can see that time to onset of first crisis, the number of acute chest syndrome, hospitalizations, cumulative days of hospitalization, and the number of blood transfusions were definitely decreased in the glutamine arm, in particular time to onset of pain crisis and number of acute chest syndrome. Even though this seems to be highly effective, there is still some controversy and not all agencies are convinced. So in conclusion, in a phase 3 trial, this glutamine resulted in a significant lower number of sickle cell disease related complications compared to placebo. 2/3 of the patients on the study were received hydroxyurea, and the safety profile was very good, and 70% of the patient continued on the trial, but there still are some questions about this. So this is again used to prevent. Now, what about selectin inhibitor? And there are 3 selectin inhibitor, 2 of which entered clinical trials: rivipansel and CELG1 or crizanlizumab. And rivipansel from Pfizer was used to try and shorten pain crisis. I have to say very quickly that after an initial encouraging phase 2 trial, a phase 3 multi-center trial showed no efficacy to shorten vaso-occlusive crisis. So here, patients admitted for vaso-occlusive crisis were started on this, and some subgroup showed some decrease in opioid use, but overall, no shortening of the pain crisis. Crizanlizumab, on the other hand, is a monoclonal antibody against P-selectin, and it was used to prevent pain crisis. And I'm going to be showing you some of these details. This is the role of P-selectin in attachment and rolling and adhesion of white cells and platelets to endothelial cells and to red cells. And you can see here how this sickle cell and white cells can block the vessel, and the crizanlizumab will prevent this blockage. So this is given once every 3 weeks, and you can see again here the blocking mechanism. And these are the clinical trials, and basically the SUSTAIN trial were used in patients 16 to 65 years of age, all types of sickle cell disease, patients with multiple recurrent pain crises, and patients had on hydroxyurea had to be on a stable dose of hydroxyurea. This was presented now a few years ago, and there was 2.5 milligrams IV every 3 weeks, 5 milligrams, and placebo. And this was presented at ASH now a couple of years ago. You can see here that there were a fairly divided group between the 3 arms, and the race of the majority were Black, mainly SS, and concomitant use of hydroxyurea. You can see here that the majority of patients were on hydroxyurea. Again, the number of painful vaso-occlusive crises, 2 to 4, 5 to 10, and the baseline characteristics, again, almost evenly distributed, with LDH values being fairly high in most of these patients. Now, when you look at the results, the 5 milligram per kilo every 3 weeks had a significant reduction in the annualized rate of vaso-occlusive crisis. It was significant compared to placebo, whereas 2.5 milligrams per kilo, the difference was not significant. The crizanlizumab decreased the painful crisis regardless of whether or not the patients were or were not receiving hydroxyurea. In fact, it seemed that there was an additive effect if hydroxyurea was used. Again, 5 milligrams per kilo was the required dose. Again, it didn't matter if patients had 2 or more or many pain crises, crizanlizumab was effective. And again, there seemed to be a tendency to be more effective in the patients who had a higher number of pain crises. You can see here, there was more decrease compared to placebo in the patients who experienced higher number of pain crises, but still the differences were very significant. Again, regardless of genotype, whether it was SS or other genotypes like common in our regions, S thalassemia, the crizanlizumab was effective in decreasing the number of crises compared to placebo. Now, again, as we mentioned, there were additional benefits compared to hydroxyurea, but it was additive, but not a synergistic effect. Okay, and there was a significant increase in the probability of being free of vaso-occlusive crisis amongst patients with crizanlizumab 5 milligrams per kilo compared to 2.5 milligrams per kilo in placebo. So more time without pain, which is clearly a major improvement in the quality of life. And this is also translated in this curve, time to first crisis or cumulative event-free rate. And the time to a second crisis was also increased in the crizanlizumab arm compared to the placebo arm. The adverse events, very tolerable, some diarrhea, some vomiting, but overall very comparable to the placebo arm. Now, some people have reported infusion-related pain, and this remains to be seen, so patients need to be watched very closely during infusion. And again, serious adverse events like infections, which we fear because of the inhibition of p-selectin, were not seen, and they are similar to the transfusion arm. So the conclusions from this trial is that treatment with crizanlizumab significantly reduced pain crisis. This reduction was apparent in all subgroups, regardless of hydroxyurea use or number of pain crises, and the serious adverse events were very few. And now in the SUSTAIN study, this is now being followed by another phase 3 trial where I am leading the steering committee to see if 7.5 milligrams will be better than 5 milligrams and better than placebo. So we eagerly await these results. In the meantime, the drug will be available for patients who are not candidates for enrollment on the study. Now, I want to mention a little bit about bone marrow transplant and gene therapy in the last few minutes. And I'm going to go about the results of stem cell transplant, haploidentical donors, and gene therapy. Again, just to stress upon you that the median survival of adults with sickle cell disease is more than 20 years shorter than that of other African Americans leading in the US. And this is regardless of genotype. And again, this obviously are my own slides, and this is from my good friend, Mike DeBon, and this is published in Blood a while back. Now, what are the criteria for bone marrow transplant in these patients, which is, could really cure the disease? And very few transplants have been done. Now, these are proposed criteria for bone marrow transplantation. Now, for HLA versus matched sibling, which is really standard of care, versus alternative donor, which is experimental. more than 2 painful crises a year, recurrent acute chest syndrome, stroke, cognitive impairment and abnormal MRI, tricuspid regurgitant velocity, which is high, pulmonary hypertension, sickle nephropathy, alloimmunization, priapism, and osteonecrosis. Now, I still consider these indications for allotransplant to be highly experimental, and HLA matched sibling donor could be considered standard of care, and you are going to see why in a minute. These are results from Mark Walter's series of matched sibling transplants, and you can see 93% overall survival, 85% event-free survival, very high rates. Similar results reported from all over the world, even better from the French group. And you can see here that using bone marrow or cord blood was significantly better than using peripheral blood stem cells, and that the incidence of GVHD is low. So very high rate of event-free survival, okay, in a large series published by Eliane Gluckman. Now, when you look at the age of transplant, it's very important to notice that patients 0 to 5 years of age had 100% overall survival, 93% event-free survival, and better engraftment, comparing to either younger and definitely much better compared to older patients. Now, the problem is, of course, with donor availability, and which only 20% of patients will have a matched sibling donor, and the ability to have serious disease recognized early in life. And you can see here that in the older patients, the results are significantly worse with higher rates of GVHD. Now, in older patients who have a sibling donor, we can use a non-myeloablative approach. This is really important, and I just wanted to mention this real quickly. But alternative donors are important. However, the results with alternative donors have not been good. You can see here that with matched unrelated donor, the 3-year event-free survival is low. There is a high rate of graft failure, and there is a high rate of acute GVHD. So MUD donors are not good, and they are also not available because most of these patients are minority patients and they don't have a high MUD available. So what about haploidentical transplant? I have to say this remains experimental, but the results are looking more and more promising. This is in a small group of patients from the slides updated very recently from my friend Josu de la Fuente in London. And again, the same results from a good results from a larger study of patients that they are doing with the Vanderbilt Cooperative, about 75% event-free survival. Still cannot be recommended for everyone, and I hope that they will improve the results. Now, in the meantime, gene therapy is coming on the scene, and we have two mechanisms for gene therapy that are currently in use. One is gene addition by adding an anti-sickling hemoglobin, and the other is hemoglobin F induction by gene editing by messing with the BCL11A. And I'm going to show you some results. This is the addition of the anti-sickling hemoglobin T8-7Q, and you can see that this patient really engrafted very rapidly and was the first patient reported in the New England Journal from Bluebird Bio. Since then, there has been a larger number of sickle cell patients reported, and you can see here, I'm going to show you really quickly. These are part of the group C patients where these were the criteria for enrollment, and they had to have failed hydroxyurea, and they looked at more than 30% of the hemoglobin T87Q, which is an anti-sickling hemoglobin. And more than 50 patients have been done. And this study looked at their quality of life, pain, interference, fatigue, physical functioning, sleep disturbance, and depression. And I just show you really quickly that pain interference with activity significantly decreased in these patients. So major improvement in the quality of life. And these data therefore represent that gene therapy with gene addition can play a valuable role in these patients. Now I'm going to very quickly show you the safety and efficacy evaluation presented at ASH last year of subjects with sickle cell disease, and also there were subjects with thalassemia treated with CRISPR-Cas9 technology to interfere with BCL11A and increase fetal hemoglobin production. As I said, there are two trials, one in thalassemia and one in sickle cell. I'm going to focus on the sickle cell patients, and the molecular approach is to introduce through CRISPR-Cas9 technology and inactivate the BCL11A gene, which will interferes with fetal hemoglobin production and improve fetal hemoglobin production in these cells. And this is how this happens. I don't want to go into the details. You electroporate the CRISPR-Cas9 technology into the cells with a lead mRNA. This will inactivate BCL11A, and you give back the stem cells to the patients after they receive only busulfan. And you can see here that hemoglobin increased, transfusions decreased in these patients. You also saw that there was a significant increase in the number of F cells. These are cells that express fetal hemoglobin. And these are the patient characteristics. Sorry, I'm going to jump quickly. The adverse events were mainly related to the busulfan, fever, neutropenia, and so on. But you can see here significant increase in the percentage of fetal hemoglobin in these patients as time went by. This fetal hemoglobin was seen, was pancellular, and there was a significant decrease, as I mentioned, in F cells. And in 3 patients that are fully reported, and this was actually updated in the Idh, there was a decrease and no evidence of painful vaso-occlusive event in these patients. So the first 10 patients have been followed and are free of sickle cell disease. Overall safety profile is consistent with the myeloablation. Clinically meaningful increase in fetal hemoglobin was observed, and this is a clinical proof of concept. The study is ongoing and accruing more patients, and this is very important. Now, this brings us to a very important point about the risk tolerance, both for patients and for physicians. And the more there is a potential for disease modification, okay, the more risky the procedure becomes, and the higher the risk tolerance has to be for one to undergo these procedures. For example, using hydroxyurea or a drug like crizanlizumab or a GBT440 carries with it some risk, but this will only modify the disease. Whereas things like bone marrow transplant and gene therapy are going to completely modify the disease, but will require higher risk tolerance. And this is something that really needs to be weighed from the physicians and the patients all together. Now, of course, added to this are the recent cases of myelodysplastic syndrome and leukemia, that 2 cases that developed among patients who were treated with the gene addition of the Bluebird trial. And now we are very carefully evaluating patients before they go into gene therapy and after they come out of it. So in summary, sickle cell disease is associated with many potential complications. Preventive measures, early detection, and early ongoing patient monitoring are valuable. Viable treatment approaches, including hydroxyurea, bone marrow transplantation, and recently the new drugs, crizanlizumab or Adakveo, and voxelotor or Oxbryta have been approved. So we have to really have a patient-centric approach for these interventions and monitor them very closely. Thank you for your attention, and I will end here, and I'll be glad to take any questions. As you can see, most of the slides were not related to Novartis, but I apologize, I could not take this out before presenting. So if there are any questions, I'll be glad to entertain them.
Thank you, Miguel, for this really very nice presentation. I enjoyed for this overview on the sickle cell. I will move to the next session with Dr. Ahmed Ibrahim, our friend and dear friend. Hello, Ahmed.
Hello.
Dr. Ahmed Ibrahim is the president of the Lebanese Society of Hematology and Blood Transfusion. He is also a professor and head division of Hematology Oncology at Maqasid General Hospital and director of bone marrow transplant program in Maqasid and also in Middle East Hospital. Ahmed today hopefully will be quick to present for all of us. We have a big regional audience today about the update on the treatment of AML. You have 5 minutes only, Ahmed, if you can.
I will try in 3 minutes because we gave me 20 minutes for a big presentation for a big disease. So I thank everybody, the co-chairs of the meetings, of the ABC, the chair of the meeting today, and the organizer for inviting me to present the AML, a kind of comprehensive and less update. I will share the slides.
Ahmed, I would also like to thank the organizers. I forgot to do that, Dr.
شكرت عنك. I enjoyed your presentation, Miguel. So I'm sharing the slides. You see the good. You hear me and you see the.
Go ahead, Ahmed. Yes, very clear. Thank you.
So I'll try in 20 minutes to talk about AML, which is a polyclonal disease, a diagnosis. And when we give therapy, a subclone acquires additional mutation than drive relapse. And a lot of work has been done the last 15 years in order to understand more understand this polyclonal disease and more understand and discovering mutations in order to better have a good diagnosis, adequate diagnosis, and prognostic factors more and more precise, and then adequate therapy for particular cases and in general. So beyond morphology, flow cytometry, conventional cytogenetics, FISH, and immunohistochemistry, and so it appeared that molecular genetics has been a key player in the diagnosis, as I told you, prognosis and treatment of this disease. You see here the classical cytogenetics entities reported by WHO And 20 years ago, we had this. We had good prognosis was, for example, good player 15, 17, and bad one with the MDS secondary -7, -5. And you have here the difference in terms of survival according to what we knew about cytogenetics. However, but genomics landscape of AML is very important, and the last 10 years, genomics has been developed and better defined sub-entities of AML with different prognosis and adequate therapy targeting this these molecular abnormalities. For example, you have FLT3 with frequent in AML, 30%, but in the FLT3 mutation, you have favorable, intermediate, or adverse prognosis according to that type of FLT3 quantity and the expression of the FLT3. You have this with NPM1 and others, as you see on this slide. And you have here the ELN classification using cytogenetics and molecular abnormalities. And you see that when you have only cytogenetics, you have some favorable and intermediate or adverse disease according to cytogenetics. But when you add molecular, in the favorable, for example, when you have low ITD FLT3, this is good. With the cytogenetics in the middle of the slide. But when you have higher ITD expression, you go to intermediate or adverse according to other abnormalities, molecular or cytogenetic associated. And a refined AML risk stratification by cytogenetic and mutations was reported last year. And you see that on the right, you have the elderly patients, more adverse prognostic disease, less intermediate, less favorable, less intermediate, less favorable than a younger patient, which induce different survival, better survival with favorable, less with intermediate, and less with adverse prognostic factors. And on this slide, you have the major molecular studies and the feature with AML in the worst, the majority in the worst situation. FLT3, ITD, 30% worse, NPM1 mutation is better, neutral for IDH1/2, and the other are worse or very poor. As you see, Sickle, BCL2 expression, MLL-PTD, the MT3A mutation, ASL1, TET2, P53, and EVI1 expression, high expression. And you see that a lot of work has been, I will show you that a lot of work has been done in order to overcome this worst prognosis by targeting these, some of these mutations. Molecular genetics helps also, particularly when you use NGS, and coupled to flow cytometry, help to identify the molecular residual disease, which is correlated with prognosis. When you have NGS positive coupled to flow cytometry positive, multiparametric flow cytometry positive, you have a higher relapse, arriving to 75% compared to NGS negativity and flow cytometry negativity. So the last years, it seemed it has been shown that it's important to do more and more molecular screening coupled to flow cytometry in order to screen molecular residual disease and to treat it earlier, and to have, and this helps to in the follow-up of the patient to improve survival. Now coming to the treatment. For patients eligible for intensive chemotherapy, classically patients were induced when they were eligible for intensive chemo or induced by high intensity chemotherapy, 3-7 or others, followed by consolidation or a transplant according to the risk, intermediate poor risk consolidation by allogenic transplant, favorable risk consolidated by chemotherapy. And since the 3-7 protocol, we are at the 50 years anniversary of the classical 3-7. This is a profile of the 3-7, 5-year survival, 20 to 35% in young and 10% in old, not very high. And it seemed that high-dose RSC induction improved outcome in AML, as I will show you in the meta-analysis of major randomized studies, ERTC, GMEMA, Australian, MRC, Italian study. You see here, for example, in the ORC, GMEMA, in younger people with high-dose RSC, you have a better survival. You see also in the MRC, we have the same results, better survival with the high-dose RSC, like in the FLAG IDA protocol. And 3-7, high-dose RSC, then consolidation. Talking about classical consolidation, which in the major cases, high-dose RSC, and it seemed that high-dose RSC at 3 gram meter square helps better for low risk and probably intermediate risk patients compared to high risk. So we had a 3-7, we had high-dose RSC in the induction and high-dose RSC in the consolidation therapy. The last years, because of the development of molecular genetics, we have now clinical application of molecular studies in acute myeloblastic leukemia, FLT3 mutation, adding FLT3 inhibitors, IDH1/2 mutation, which adding IDH inhibitors, NPM1 mutation in diploid cytogenetic, RSC sensitivity and Ven sensitivity is here, TP53 mutation, where we can consider decitabine or others, but or new agent, but allogenic transplant is still the indication, and recently menin inhibitors for MLL-r. And we still have problems with the RAS mutations. So clinical molecular genetics helps to use target therapy and clinical application of target therapy for some of these molecular abnormalities is here. I will start by FLT3 mutation, 25% RTD, 5% TKD, and I would like to show you the major study using anti-FLT3 inhibitor, midostaurin, plus 7-3, ratified study, compared 7-3 plus midostaurin compared to 7-3, and effectively midostaurin helps with higher survival, median 74.7 months compared to 25.6 months to the placebo, and 7.2% difference in overall survival in 4 years. And then the secondary endpoint, which was the EFS, also significance in terms of long-term, in terms of EFS with midostaurin plus 7-3. And now we are in the era as usage of other and newer anti-FLT3. And here you have what was presented at the ASH 2020, the phase 1 study of 7-3 plus gilteritinib. And you see a good curve of survival. We need more follow-up, but probably better than 7-3 plus midostaurin. We reach 70% at 3.5 years. We know that hypomethylating agents plus anti-FLT3 are also in studies, and here you have a major study, the LACE-WING study, comparing gilteritinib to gilteritinib AZA versus AZA, 3 arms, 250 patients with this new anti-FLT3 gilteritinib. But the first reports, and we need time to have more and more precise conclusion about the study. And in the ASH, this study was presented but failed to meet survival, so we have to wait. We know that AZA and venetoclax has been used the last few years widely in AML, particularly in patients who cannot tolerate intensive chemotherapy. Does venetoclax help for FLT3 mutated patient? We can obtain, as you see on this slide, on the study presented at the ASH also 2020, 68% of FLT3 ITD obtains with a higher also survival in FLT3 mutated patient. And you see that CRI, as I told you, and overall survival higher in FLT3 mutated patient received venetoclax versus venetoclax plus placebo. And in patient with FLT mutated AML, response rate and overall survival is similar to FLT3 wild type. So FLT3, Vidaza and venetoclax brought the mutated to the result of the mutated to similarly to a wild type, but still, but these results, the survival is lower than. Cannot compare exactly, but the curves are lower than with anti-FLT3. So anti-FLT3 is still in combination the treatment for FLT3 mutated patients. Now coming to IDH mutation, we know that IDH is a critical enzyme of citric acid cycle, and it's produced 2-HG that alters the DNA methylation and blocks cellular differentiation. And IDH1 is present in 7% of the patients with AML, while IDH2 in 15%. And we have two drugs, an anti-IDH2 inazidenib and ivosidenib, which is the anti-IDH1. And here we have the profile of the results as presented recently with anti-IDH1 or anti-IDH2 with a 37. We have almost 75% probability of being alive at 1 year after treatment, after induction therapy. Against does Vidaza plus venetoclax, one patient cannot receive 37 plus anti-IDH helps. You see here that it could help, but it is not the same result than with the anti-IDH1 or 2, but we can approach 40 to 50% survival at 2 years with Vidaza venetoclax in patient with IDH1 or IDH2 mutation. Coming to targeting NPM1 mutation in AML, and here you have the role of hypomethylating agents plus venetoclax, particularly in elderly patients with CR rate 88%, 1 year overall survival 80%, and median overall survival not reached. We see on the right of the slide, on the blue curve, that you have very good survival with hypomethylating agents plus venetoclax in NPM1 patients, particularly in elderly, compared to chemotherapy or hypomethylating agents alone. The problem is still here with the P53. Here you have azacitidine with APR246, which is a methylated derivative of prima-1, which induce apoptosis in human tumor cells, and targeting mutation P53. Still not good results. And the need of allogeneic bone marrow transplant to obtain acceptable survival at 2 years, in 1.5 years, 2 years. A new treatment target therapy is magrolimab, which was tested in P53 patient. This is an IgG4 anti-CD47 monoclonal antibody that promotes tumor cell elimination through macrophage phagocytosis. And you see on this recent study presented at the ASH last year also, where the majority of the patients, 75%, had P53, and they received AZA plus magrolimab. And you see here that in the wild type, we have acceptable result, while in the P53 mutated, we don't have, we didn't obtain significant and optimistic result. However, CR rate was almost 70%. Does hypomethylating agents added to venetoclax do this? Is this combination effective in p53 mutant patients, newly diagnosed AML? Not very convincing. It was associated with inferior response, shorter response duration, higher MRD positivity, inferior survival outcome. However, when we don't have any other alternative, we can use this decitabine or hypomethylating venetoclax. Coming now to the secondary AML. We know that secondary AML with the classical chemotherapy, treated with classical chemotherapy, has a very bad survival. And you see on the right that survival is very low, not exceeding long-term 10%. Why? Because of the spectrum of somatic genetic mutation, particularly ASXL1 plus SRSF2 and SF3B1, U2A, ZRS, STAC2, BCOR, and EZH2. And the CPX351 combined to chemotherapy 37 did something very interesting in this setting. CPX is a dual drug liposomal encapsulation of daunorubicin and cytarabine in a synergistic 1:5 model ratio. And in this famous phase 3 study, CPX37 was compared to 37 in induction, then 5:2 plus 5:2 as consolidation chemotherapy was compared to CPX in consolidation. And you see here the characteristics of patient, almost 300 patients. And you see clearly the overall survival in all patients who achieved CR or CRI in this very, very dismal disease was acceptable. And particularly patients who were brought to a transplant, to allogenic transplant, did very, very impressive, had impressive result with impressive 5-year overall survival in responding patients, about 56% at 3 years compared to 37 only in this very, very aggressive disease. Coming to the combination of FLAG-IDA or FLAG anthracycline plus venetoclax, and Iman Abdel presented in 2019 first results of FLAG-IDA venetoclax, and it was updated in the ASH 2020. You see here 3 phases, 1B in relapse and 2B in relapse. So 2A is our concern today, newly diagnosed AML. 29 patients presented at the ASH 2020 with cytarabine, with the flag, with cytarabine moved to 1 gram meter square, that venetoclax 14 days, because the problem is toxicity. It started by venetoclax 1 month and 21 days, 14 days, which seems logical. And you see here the impressive result in the newly diagnosis in terms of overall survival. You see on the right, on the summit of the slide, this green curve approaching 90%. This is a wonderful, wonderful combination. We are using it now, and we will present at ASH our experience with 22 patients, but in relapse, using FLAG-IDA plus venetoclax. We will send it to the ASH this year. Which is important to maintain the response in patient treated with target therapy plus minus chemotherapy. And here we have the famous phase 3 recently presented at the ASH 2020, the Quasar AML-001. One patient who aged them more than 55-year-old obtained a remission that consolidated with a few cycles of chemo, of therapy. They received, and bad performance status, intermediate and poor cytogenetic, not eligible for transplant, received CC486 oral azacitidine versus placebo. And clearly this maintenance was very interesting because oral as a CTD maintenance, improve overall survival and relapse-free survival independently of MRD status as benign. Oral as a CTD was associated with a higher rate of MRD conversion response from positive to negative, 19%, and MRD positivity was associated with shorter overall survival and RFS versus patient with MRD negativity. So ideal for MRD negative, but also helping from MRD positive. Coming to a patient who are elderly or ineligible for intensive chemotherapy, classically they received hypomethylating agent plus minus low dose RSC and continue hypomethylating agent until progression. With this, the survival, as you see on the right, for these elderly patient or comorbid patient are very good, not exceeding 15% at long term. And a recent study, the Viale A study, compared venetoclax AZA versus placebo AZA for this kind of patient, more than 75-year-old, more than 18 comorbidities, ineligible for standard chemotherapy. And you see on this slide that CR rate was higher, significantly higher than with the venetoclax and Vidaza versus Vidaza alone, with the time to first response lower 1.3 months with the venetoclax AZA versus placebo AZA, which was almost 3 months. And here you have the overall survival significantly higher with venetoclax AZA compared to AZA placebo, making this combination a very interesting one in comorbid patient or elderly patient. And recently, the usage of glasdegib, which is an oral inhibitor of sonic hedgehog pathway, which is eliminated in AML and obtained the FDA approval in 2018. The BRIGHT AML trial, 100-003, which showed a survival benefit was glasdegib low dose RSC versus low dose RSC alone, particularly in good and intermediate risk patients. You hear me?
Yes, Ahmed, we exceeded the time. Please,
Yeah,
if we can go faster.
2 minutes. Now we can think about now recently also the combination of venetoclax, cladribine, low dose RSC alternating with 5 AZA for newly AML has been investigated with very interesting overall survival, higher overall survival in MRD negative patient. We have atolimab, we have to newly diagnosed AML, we have to wait for the result. I can for this, and I will finish by immune-based approach in AML, particularly bispecific in the future, T-cell-based therapy, bispecific immune checkpoints, CAR-T, and vaccines. And I will present you the, which is has been reported and done currently, anti-CD33, the emtricitabine, ozogomycin. The meta-analysis of 5 AML randomized trials showed that with this drug coupled to chemotherapy, we improved in survival, reduced in relapse. And particularly, you have here the Alpha 0701 phase 3 study comparing Dono RSC plus anti-CD33 plus minus anti-CD33. And you see that in the ELN favorable and ELN intermediate, adding anti-CD33 did the good job with the higher, significantly higher event-free survival in both favorable, intermediate, and the relapse survival was also higher by adding anti-CD33 to chemotherapy. The other antibodies are coming, 123 and 123 bispecific. Also, antibodies in AML are coming in the near future. What we have in FDA approved drugs in 2020 from 17 to 20, midostaurin for de novo AML, FLT3 mutation, gilteritinib for FLT3 and relapse, inazidenib for relapse, coming anti-ADH2 plus coming the future first line, Evo, Zidenib in relapse, August 2018, CPX for newly diagnosed secondary AML post-LDS, anti-3 device are now used for intermediate and low risk patient. Venetoclax are in the market now, as I showed you, plus Dejib also for newly older and fit patient with RSC, and oral decitabine, oral azacitidine as maintenance since December 2020. Practically, we are using FLT3 inhibitors, IDH1/2 inhibitors, CD33, and anti-CD123 coming, venetoclax, and maintenance with oral azacitidine. And here the last one, you can see the slide how to approach AML. In patient eligible for intensive chemotherapy, CBF AML, anti-CD33 plus intensive chemotherapy, FLT3 mutation, anti-FLT3, you go to transplant. For secondary or post-MDS, CPX 351, and we get we can go to transplant. We can also use a venetoclax or a Glasdegib or IDH1, IDH2 inhibitor when available. And the patients who are not eligible will receive hypomethylating agent venetoclax, or those that receive venetoclax, or those that receive Glasdegib. When we have FLT3 inhibitor, we add FLT3, and IDH2 inhibitors also are in the here to be added to these combination in case of anti-IDH1 and anti-IDH2. Some patients who are not eligible at the beginning could be eligible for allogeneic bone marrow transplant after the success of these induction therapy in ineligible patient for intensive chemotherapy. I would like to thank you for your attention.
Thank you, Ahmed. I appreciate it. Was really a big topic to be summarized.
I don't hear you very well.
And now? Anyway, Ahmed, you did a very good job with this presentation. We exceeded.
ما عم بسمعك انت منيح. I don't. أنا ما سمعتك منيح جون بس لأنه هلا.
عم بيقول لك you did excellent.
The problem is yours, Ahmed.
بس لأنه ما عم بسمع.
Yes, but maybe.
Yes, I know. I had some problems with net. ما أنا قاعد حد نبيه بري.
Okay, you should be.
We have this problem.
You should have maybe a better connection. Anyway, you did a beautiful presentation. So we will move rapidly to the invite our colleague to the panel discussion. I'm delighted to invite Dr. Iman Abu Dalle, my colleague in our center at AUBMC. Dr. Iman is instructor of clinical medicine at the Division of Hematology Oncology Department of Internal Medicine at AUB. Our colleague, also Dr. Safa Al-Azawi, Senior Consultant of Hematology at Hamad Medical Corporation, Qatar National Cancer Center Care for Treatment and Research. Welcome, Safa.
Thank you so
much. Dr. Murtada Al-Khabouri, our friend from Sultanate Oman. Dr. Murtada is Senior Consultant Hematologist and Bone Marrow Transplant at Sultan Qaboos in Sultanate Oman. And I'm sorry if I missed your name initially, but anyway.
Thank you, Dr. T.
Let's start. I don't have any question for both either Miguel or Ahmed about the presentation. So I want to maybe leave free my colleague and the panelists to debate, or maybe to ask Dr. Miguel or Dr. Ahmed about the evolution of the treatment, either for sickle cell initially and later on with AML. As we can see, a big revolution in the treatment in this two difficult diseases, two different diseases in the last 10 years. So we have multiple molecules, different combination, different drugs. The outcome is different. The toxicity is less. The patient become better to the transplant when it's indicated and possible. So, and hopefully in the future, the treatment will be more feasible and more potent. And as you can see, all the treatment advancement was based to the better understanding of the disease per se, and also better understanding of the physiopathology of the disease, the clonal evolution, and after many trials and studies, we have the opportunity to have different multiple drugs, oral medication to treat what it was non-curable 10 years ago. Any comment from the panelists?
Dr. Jain, can I start?
Yes, go ahead, Murtada.
So the question is...
How are you, Murtada? Murtada is here.
Alhamdulillah, the question to Dr. Magil Aboud. So when you look at the studies of sickle cell disease, there are two different strategies, prophylactic versus treatment. There are different approaches, anti-selectin P2, the polyximer, and other approaches, and then the choice of the outcome. Now, what is persistent among all of those probably is the choice of the primary outcome and other important secondary outcomes. But you see an observation that whatever study that chose prophylactic, it has a better chance of being statistically significant versus a study that went into reducing the duration or the opiate use. So are we using a wrong strategy when we go with a treatment, or we're using different, a wrong approach or a wrong outcome?
Yeah, it's an excellent question. And I think that there are two issues involved. For once, once a pain crisis starts, as I said, it has its own, defined by Ballas, its own lifespan. And most people believe that the horse will be out of the barn, and it is very difficult to interfere with this process once it's already started. Now you add to that the difficulty in picking an endpoint. Is it when people are ready to go home, readiness for discharge? Is it the actual dose, the number of milligrams of morphine or other opioids that they have received? Is it the lack of pain? When do they stop using the PCA? And as you mentioned, it's very difficult. But, a significant amount of effort has gone into this. And poloxamer has been tried. The paper is now in press in JAMA. No impact on the duration of pain crisis. The rivipansel took a lot of data from that. No impact on the duration of pain crisis. So these are two critical studies. Also cevuparin, they modified heparin, looked at the same, actually longer time of pain with cevuparin. The paper just came out in Lancet Hematology. So I think that it is more a pathophysiologic issue, that it's very difficult to interfere with the sickling process and the pain once it sets off. It's easier to prevent it, from happening. Hydroxyurea, very effective in preventing. Crizanlizumab, quite effective in preventing. Transfusions, quite effective in preventing. Even transfusions, or exchange transfusions don't usually abort a pain crisis. So I hope I answered your question. But yes, there is a problem with picking the endpoints, and this perhaps needs to be restudied and very carefully reevaluated.
Can we ask?
Go ahead, Safa.
يا مساء الخير مساء الخير للجميع. Thank you for organizer to invite us for this very interesting meeting, and we would like to thank both Dr. Ahmed and Dr. Michael for this interesting speech. So just my question to Dr. Mikhail regarding your approach to pregnant lady, as we know that usually pregnant lady with sickle cell anemia, they have high mortality and morbidity. So what's your approach to prevent to have very good outcome for those patients?
Hey, you know, I have recently started seeing patients get pregnant because I've been here in Lebanon 20 years. So the ladies are growing. And what we usually do is we start transfusion and stop hydroxyurea. And we maintain simple transfusion throughout the pregnancy. And at the end, we restart hydroxyurea and then we stop transfusions. This is what we do. Now, some people would argue that not everybody needs to be transfused during pregnancy. Now, if somebody is not on hydroxyurea, then I wait and see if they start having severe anemia or pain. I started on a regular transfusion regimen. You know, our French colleagues like to do exchange transfusions for pregnant ladies. We have so far stuck with simple transfusion for the ladies who need it, either the overlapping with hydroxyurea, stopping hydroxyurea, then overlapping with hydroxyurea, stopping transfusion, or starting transfusions when there are pain crises or severe anemia in pregnancy. Very few pregnant women can get away with it without the transfusion. I have to tell people to be careful because a lot of women stop hydroxyurea in order to get pregnant, or once they find out they are pregnant. And this is a typical situation where you can have rebound pain and they have a lot of pain. So really you have to be very careful there. I don't know if this answers your question. Of course, also, you know, we coordinate with the gynecologists, monitor very closely, nutrition, and all the other issues.
Do you routinely start of them with the low dose aspirin, and some may use low molecular weight heparin for specific?
You know, I leave this to the gynecologists, and they do, yes, at the end of pregnancy, they start them on low dose, on low molecular weight heparin. I'm not aware of aspirin.
Okay, because aspirin, in fact, there is interesting that in some studies showing it is effective to prevent some painful crisis and also have very good.
Yeah, but listen, when you look at the randomized study of even more potent antiplatelet agents in non-pregnant people, they did not prevent pain crisis. And these were very good endpoints. You know, ticagrelor did not do it, prasugrel did not do it. So I'm not very fond of antiplatelet agents. You know, I recently reviewed the guidelines of, and again, I don't see that many pregnant ladies, but recently I reviewed the guidelines of the British College of Obstetrics and Gynecology, and they have very good guidelines there on the low molecular weight heparin. So I'll refer to that for sickle cell disease.
Thank you.
Miguel, any update about the disease during the COVID-19 era, the risk for the patient?
We gave several updates. Overall, patients did well. Here in Lebanon, we had about, and Oman has published a large series of patients from Oman. And overall, the patients did well, but some patients got severe acute chest syndrome. And the mortality was higher than the general population, particularly that these were relatively young patients. We lost one patient out of probably 10 or 15 that I know of. And the message was to observe the patients closely and to do a simple transfusion or exchange transfusion if they got into any kind of respiratory problem. And now, of course, it's clearly indicated that all of them should get the vaccine, as soon as they have it available. And I would prefer to use one of the mRNA vaccines, not the ones that are associated with thrombosis, even though there is really no data for this, but that's a personal preference. And two, if you have it available in the US after exposure to COVID, it's indicated for patients with sickle cell disease to get the cocktail of monoclonal antibodies, either from Lilly or from Regeneron. So there is a clear indication for that. So a patient with sickle cell disease who's exposed or has the disease early, needs to get those antibodies because it really prevents hospitalization.
Thank you, Miguel. Very clear answer. I have a question from Dr. Murtada on the chat for Dr. Ahmed Ibrahim.
Yes.
What is the optimal induction for young patient with FLT3 negative AML?
This is a very interesting question. If you, the basic is 3-7, but we can go to high dose RSC in induction therapy, and it was used. For example, a few days of RSC continuous infusion high dose, and why not flag idarubicin, for example, venetoclax. It depends of the non-FLT3 molecular situation and of the availability of the drugs in our institutions.
I have a raised hand from Dr. Safa. Dr. Safa.
Yeah, again, Dr. Ahmed Ibrahim, do you usually incorporate FLT3 inhibitor with as induction? You have a time to get the molecular testing result within short time, and you have.
If you have, we in Lebanon at AUB in our institution, we can have FLT3 inhibitor, FLT3 mutation quickly, so we can incorporate it in the induction therapy. We have a few days to put it, so we can incorporate it, awaiting the results, which could be in few days maximum. And then we continue induction plus anti-FLT3s and consolidation and FLT3s. Then we go to transplant, and then after allogenic transplant, as in AUB, we are using sorafenib at least for 2 years after allogenic transplant as maintenance.
As well as IDH.
IDH is not so easy.
Not okay. Thank you. Because we are
FLT3 clearly, yes. IDH is not.
Because usually in our
institute,
we are not getting the result within very short. Usually takes time.
But we can have IDH1 or IDH2 mutation early, like FLT3. But in Lebanon now we don't incorporate it in first line. It is in relapsed and refractory, and it is not registered now in Lebanon. Not yet.
Yes, thank you.
The same situation than in your country.
Yes, it's the same.
May I ask a question?
Iman.
Go ahead,
Dr.
Iman.
Ibrahim.
Iman,
Yes.
and she presented last year the flag IDA venetoclax before the presentation of the successive one, the following one in 2020. So she started herself by presenting it.
Yes, so thank you for the nice overview. As you've mentioned that there is a lot of new drugs approved now or under investigation, acute myeloid leukemia, and then we're moving to a single patient level where on molecular targeted agents. But it's very interesting that BCL2 inhibition is basically universal for all subtypes of AML. It works on the leukemia stem cells.
Exactly.
Do you think that venetoclax is being moved to as one of the backbone treatments where you add it to chemotherapy or any hypomethylating agent, and then move to a triplet or quadruple treatment in acute myeloid leukemia?
Exactly. You are right, because the results of venetoclax vidaza for patients, who cannot tolerate chemotherapy or intensive chemotherapy not feasible. So the results are very interesting in the Viale, and the flag IDA, the result flag IDA from MD Anderson plus venetoclax are very good, and you see that you are approaching higher and higher complete remission and survival, approaching 80s and more. And when you alternate, particularly recently in elderly for more than 70 years old, you alternate cladribine with venetoclax, vidaza, and low dose RSC, you see the result. So I think it's coming first line for the majority of the patient because of the interesting results reported and the activity of this drug in combination with other drugs, targeted therapy or chemotherapy. We can, in the future, think about triplet therapy if you have anti-FLT3, for example, associated to other targeted therapy or target-based chemotherapy. We have to pay attention probably to the toxicity, Emmanuel. No, that we have hematological toxicity and infection when we use venetoclax for more than 14 or 21 days. Recently, the IHA 2021 group from Germany presented a flag idarubicin plus 7 days RC in first-line therapy, I think, not in relapse, in first-line therapy in patients with AML, and they obtained very interesting results. We are preparing our abstract for the ASH for the 22 patient, where in comorbid patient, mini flag, a kind of mini flag plus idarubicin plus venetoclax for 7 days, and we don't have bad results. So the question is, how many days and the dose of venetoclax? How many days? Because
yes, sure. So sure, the optimal duration of venetoclax and the dosing with this combinations is still not known.
Is a crucial question now. Yes.
It will be more difficult when we're moving to the triplet and the quadruples regimens.
Yeah. Because if you put it in the quadruplet regimens, probably we have to use it shorter because we will be toxic.
Yeah, sure.
No. I have a question on the chat to Dr. Miguel from Dr. Ahmad Maghable. What are the indications for RBC's exchange in sickle cell disease? And the second question, how do you manage a pregnant lady with recurrent sickle cell crisis? I think the second question we already answered about it. Miguel, any brief comment, please, and for the first question, thank you.
Yeah, so listen, for exchange transfusions, patients who developed an acute ischemic stroke, children, they do better with exchange transfusion. Patients with acute chest syndrome who are progressing rapidly do better with an exchange transfusion. Anytime when you want to transfuse and the hemoglobin is high, so you don't want to really push the hemoglobin to 12 or 15, you need to do an exchange transfusion. So in some patients, preoperatively, very high-risk patients might need that. Usually we do a simple transfusion. So these are the indications: stroke, acute chest syndrome, occasionally preoperatively, or any time when you want to increase the hemoglobin very acutely. When you want to, to do a transfusion, but the hemoglobin is very high. And again, for pregnancy, we talked about transfusion, dose observation, and I just double checked. The British use low dose aspirin during pregnancy, and low dose heparin as well. It's in the Royal College of Obstetrics and Gynecology guidelines, but I would defer to those. So this, in addition to transfusions in ladies who need it, who have serious conditions before, who have been on hydroxyurea, or who develop severe anemia and pain during pregnancy, or who have other high-risk pregnancies like pregnancy, and so on.
Dr. Sheikh.
I have a question for you from the audience, Ahmad. How do you manage a patient with ML and positive COVID-19?
It's good, but I would like to
and it will be, I think, because we are very late.
Yes, but
the last question.
To be comprehensive for Murtada, because he asked me about induction therapy. Cladribine is also in the combination, and cladribine in elderly patient, and vidazabine venetoclax also. So in the COVID-19. We used a 3-7 protocol for the patients. We didn't use some patient developed COVID in our institutions, I think in yours also. And COVID-19 we haven't used the fludarabine in the induction therapy because this is a very immunosuppressive therapy. So we try to be very classical and not using venetoclax also because of the possible hematological toxicities, which would be longer than with 3-7. So we use the 3-7 frequently more than we use the 3-7 more than the other 3-7 for these patients.
In our experience,
for patient eligible for intensive chemotherapy, okay, not for.
In our experience, we noticed that we have maybe lower incidence in COVID positive for patients with ML, either induction or consolidation, or maybe in transplant patient, elderly or young. So the incidence in ML was strangely very low compared to other patients with lymphoma, and especially the multiple myeloma patient, as hematological diseases had highly affected and with higher mortality rate in our myeloma patient compared to
but
ML.
Some people reported with AML is in Italy, for example, to report that AML.
Maybe it's related to the epidemiology. They have more elderly patient compared to other Western European countries.
But we face some problem with AML with COVID in our institution.
Obviously, but compared to other
compared
diseases,
to multiple myeloma higher. I agree with you.
Yes. Anyway, I will. If we don't have any other question, thank you everybody. Thank you our panelists, our speakers. Thank you Dr. Fadi Farhat for this nice meeting. It was virtual, but it's very nice to meet our colleague from Jordan, Syria, Sultanate Oman, Qatar, Lebanon, and Tunis also. So it's very nice, and I think it's very nice to repeat and to be maybe for different topic in the future. Thank you everybody again, and hope to see you safe as soon as possible, and maybe in Beirut next time. Thank you everybody. Fadi.
Thank you.
Good to see you all.
Thank you.
Thank you.
Thank you so much.
Good evening.
Thank you, everyone.
Yes.
Thank you.
Thank you, and see you in the next session, hopefully, dear.
Thank you.
Okay, we'll invite you again. Bye-bye. Thank you.
Bye-bye.
And have
Thank
a
you,
nice
Fadi,
evening.
for the invitation.
Thank you,
Thank you,
Bye.
everybody. Thank you, Fadi.
Bye. Bye.
Thank you, Father.